you so much. So the floor is open for questions. We have a microphone over there, so we just ask that you go over to the microphone. But before that, I just want to thank Dr. David Macklin. I think your superpower is definitely taking these big concepts and making them into digestible bites, pun intended, and always with the guiding current of compassion and empathy. So I thank you. Yes. So who has a question? Who would like to go first?
Thanks, David. That was awesome. Your last point about the reflection, when people say no, you answered about when people say no, it's time to roll up your sleeves and to get back on track. We just wrote a paper on people that lose weight multiple times over and over again and regain it, but can still win. So that was the concept of the article, was that you can still win even when you've been demotivated from losing weight multiple times. I wanted a little bit more about that, like how to not beat yourself up, how to actually think that you can roll up your sleeves. That's sometimes not such an intrinsic characteristic. Can you lead us down the road as to how someone can not beat themselves up and really feel that they're worthy enough to get back on track?
Thank you, Sean, for the excellent question. Sean Wharton, the chair of the Canadian Clinical Practice Guidelines, obesity physician extraordinaire. Thank you for the question. What Sean has asked about is, in fact, could be called, because you mentioned it almost as a trait. So the trait is called resilience. So check this out. This is interesting. Okay, so someone reflects on their day and they find that it was not aligned with their values. What's the risk of that exercise? The risk of that exercise is ultimately self-criticism. So this starts because this is a concept of CBT, where cognitive behavioral therapy fits into obesity treatment. Right? You hear a lot about CBT. You're going to learn exactly how it works in the next 3 minutes. Humans are automatic thinkers. Do you guys know that we have two thinking brains, one that's really fast and automatic, it runs most of our day, and one we're quite reluctant to use, which is a slow thinking, deliberate brain, which is exhausting. You know when you drive a car for 2 hours and you're exhausted? It's because you had to use your brain the whole time, which you're not really excited to do. How far am I from that car? Am I in between the lanes? Am I in the right place? You actually are physically exhausted from using more energy in your brain. We are automatic thinkers. I'll prove it to you. Okay, I need everyone to answer this question out loud. Don't be shy. First of all, I need everyone here to say this is proof that we are automatic thinkers. And then I'll ask you to do something and ask a few questions. So, I need everyone here to say the word white 7 times, please. And go. Excellent. And what do cows drink? How many times did we hear milk in the audience? Right. So what just happened there? The human brain is So the automatic thinking brain, again, which runs most of our decisions, heard the words cow, white, and drink. I mean, come on, the answer is milk. Let's move on. And the answer comes into the head. It's an automatic thought that you cannot avoid happening. Even if you said water and you didn't know this exercise, you first thought milk and then stopped and said, well, wait, that's not right. The first thought that entered into, so it turns out that when we struggle with a behavior all our lives, and then we experience a setback, we will experience a thread, a storm, a hurricane in some cases, of automatic thoughts that are also wrong, just like the word milk is wrong. But these thoughts come automatically and they speak poorly about who we are as a person and our capacity to manage our weight. They will sound something like, 18 years I've heard these thoughts and helped people challenge them. They'll sound like, ugh, why did I do that? What was I thinking? Here I go again. What does that say about me? It says that I don't have enough willpower and I'm not strong enough. And I should be able to do better, but I'm not. What does that say about the likelihood of you succeeding long term? Well, it says that I'm not going to succeed. Clearly, I can't do this. It's never going to happen. It's too hard. The root thought there is, it's too hard. I can't do it. It's not going to work. So in other words, a setback will happen, and that will be followed by an automatic storm whose root thought is it's not going to work and I can't do this. Thoughts lead to emotions. So the emotions from that line or string of thinking is frustration, disappointment, in worst case scenarios, demotivation and resignation. So if the thoughts are automatic and they come as automatically as the word milk, then it becomes the clinician's and the individual's challenge of simply recognizing these thoughts. In fact, I'll leave this with you all as homework. If you experience a setback and you feel a negative emotion, you say, oh, this is what Macklin was talking about. He said that in this moment, automatic thoughts came into my brain that spoke poorly about me and my capacity to do this, and that those thoughts are from a lifetime of learning, but they're in the automatic parts of my brain. And if I stop and pause and notice them, I can ultimately change this line of thinking. Cognitive restructuring is the mechanism of cognitive behavioral therapy. Cognitive restructuring, changing one's thinking. So eventually, someone has a setback, but because they've, for example, received treatment, ethical, evidence-based, and effective treatment, that's the best way to build resilience, learning that obesity is a real disease, understanding what drives it, understanding that it's not their fault, have internalized weight bias countered and challenged. Great, that's what we all do as clinicians right away. And then the same setback will happen, and you'll start to see someone will say, oh, okay, what a great reminder how tough this is. What a great reminder how this is a lifetime journey for me. But my past is not evidence as to how I will do going forward because I was never once treated for this chronic medical condition. Sean Warden keeps telling me I was never once treated for this medical condition. How could my past be evidence as to whether I can do this or not? And so we see a transition in what is called self-efficacy, the belief. So you go, it's a spectrum. Over here is, I can't do this, it's not going to work, it's too hard. Even when I do well, I mess up and I regain weight, and so it's never going to happen. And you see in treatment, eventually it's like, you know what, maybe they've been introduced to an effective anti-obesity medication and a caring and compassionate healthcare practitioner. And now they're starting, maybe I can do this. And then eventually we see this now quite regularly and thankfully, where someone says, you know what, I think I got this. I can see now months and months have passed, and I'm living a life that is sustainable and livable and enjoyable, and I can do this long term. I'm certainly losing weight and finding my best weight. And so I get, you know, I really think I can do this. I feel more confident. They have more self-efficacy. And so what changed in that last effort, Sean? It's a really interesting question, right? How did they transition from a belief that they couldn't do this to a belief? Michael Vallis will say the strongest predictor of success in behavioral weight management is self-efficacy. The belief that, you know what, I think I can do this. And eventually, I know I can do this, right? You hear people having setbacks in weight management who have high resilience scores, and they're saying, I know what to do. I know when I do it, it works. I know when I do it, I feel good. I know when I do it, all the results that I'm looking for happen, so I'm going to roll up my sleeves and I'm just going to do it because I know I can do it. And when I do it, it works. And all the old thoughts have just become displaced, right? They don't register anymore. What about it's too hard and you can't do it and you don't have any willpower? Those thoughts don't even fit anymore. They don't really work. That's called cognitive restructuring. That's the foundation of cognitive behavioral therapy. The most important, one of the two most important automatic thoughts an individual will look to challenge in weight management is the thoughts that follow a setback. Beware of the thoughts that follow a setback. What are the classic setbacks in weight management? There's really three. You know, you spend 18 years hearing about setbacks and you see, oh my God, there's really only three categories. The three categories of setbacks someone will experience are being in the aftermath of an off-track eating or drinking behavior, getting on that scale and seeing a number that's not in their favor. It's like, what? Or being exposed to one's image in a mirror, in a photograph, in a reflection of a building. Those are the three events that will lead to that string and storm of those thoughts. So a clinician will lean in and say, by the way, I don't know if you know this, but setbacks are extremely common in behavior change, and here are three classic setbacks I'm suggesting you are going to experience. I'm wondering if you would consider what we know, which is that your success will not be determined based on whether you have these setbacks. Your success will be determined based on how you respond to these setbacks. And right now, there's likely an obstacle of a storm of negative and automatic thoughts that happen in the immediate aftermath of these setbacks that leads to frustration and disappointment and demotivation. And would you consider just listening or noting or finding or discovering or qualifying what these thoughts are? That becomes the homework. Next time you feel a gut level frustration, disappointment in your methods of trying to manage your weight, you should stop and say, oh, wait, this is it. This is one of those moments. Okay, yeah, what just happened? What was I thinking? Oh yeah, it's all those old thoughts again. Just noticing it is a big key step in making that change. Congratulations on the paper, Sean. Yeah, I peeked through it. You just sent it around today or yesterday, right? Yeah, that's really good. So it's a long-winded answer, but a really nice chance to kind of tie in what cognitive behavioral therapy, CBT, is in weight management.
So when you have a patient who has been very clear about their values, how do they conjure those values up when in the face of a very intense craving and use them?
Right, so what Sandra, correct me if I'm wrong, right? The question is, okay, we figured out I want to be in the direction to where my weight and my health is least preventing me from being this active grandparent, being able to enjoy long trips with my family and my kids and my grandkids and hiking and spending time at the cottage and going up and down the stairs. Like, this is what I'm in for. This is why I'm here. And then what happens if those intrinsic values face a very strong craving? So, a kind of a fun obesity medicine point. So the respirologists, lung doctors, have it really easy. I'll explain why. When they treat asthma, they ask about the symptoms of asthma. And they treat asthma often with medications. And so the symptoms that they'll say, right? They'll talk about coughing and wheezing and shortness of breath, and they'll say, how's your coughing? How's your wheezing? How's your shortness of breath? The person they're asking knows exactly what they're talking about, and the clinician knows exactly what they're, and if they initiate treatment, they can have the person come back and say, hey, now how's your coughing and your shortness of breath and your wheezing? Oh, my wheezing's better, my short, right. So what's tricky for the obesity clinician? So if we treat asthma, we're treating wheezing, coughing, and shortness of breath. If we're treating osteoarthritis, we're treating joint pain and immobility. If we're treating obesity, what's the symptom that we're treating? So a really good answer, eating behavior. So, but eating behavior is actually an outcome of the symptom. It's actually a really because look at the disadvantage we're at. We're like, we are treating a symptom in patients and they don't know what their symptom is and we're having a difficult. So it turns out the symptom, the main symptom of obesity is in the subconscious recesses of our brain and therefore inaccessible to most of us. And it's exactly based on the question that Sandra was asking. She was asking, what if their values meet up with a craving? What is a craving? A craving is a desire for sugar and fat. It's a drive. It's a motivation. Here's what I'm going to retire when a patient comes in and I say, how are things? You know, we've never met before. You're here to talk about your weight. You know, how can I help you? Well, Dr. Macklin, you know what I'm here for? What happens is I'm born with a genetic vulnerability that cues in the environment will stimulate and activate a surge of dopamine in my midbrain. And that surge of dopamine will steal my attention away from whatever else I'm doing and laser beam focus my attention on food and on getting food, finding it and going and getting it and having it. And this reflexive neurological event that happens in my subconscious is very difficult to self-regulate against, even though I know my values and what's important to me. It's still, especially if I'm tired or stressed, I'm like, excellent. That's exactly why you're here. That's perfect. I couldn't agree with you more, right? And so we have this difficulty of pointing out what is the main symptom? What drives someone to pick up a cigarette? So someone sits in their car and they turn the keys and the radio turns on and they see the dashboard, and what happens? This is a smoker. What happens immediately next? They grab their cigarette and they light their cigarette. Did they light their cigarette because just by coincidence at that moment their nicotine levels were dropping precipitously and they were having a need for nicotine? No. It's because the set of cues that has thousands of times been associated with a cigarette is what they're experiencing, and their subconscious brain is generating a craving for a cigarette, and they will not even be aware of it. They just know this is when I smoke, and they won't realize that they're now subject to that midbrain neurological reflexive event that surges dopamine and drives my attention bias is another name for cravings. It means I want to be thinking about this. I was speaking to a patient today. She was in a boardroom, and it was an important meeting, but the food on the table was stealing her attention. Like, she wanted to be listening. right? And so evolutionarily, that makes sense. If there's an opportunity for dense calories, then of course you're going to want to have your attention stolen to that. It makes perfect sense. But then you collide that with a modern obesogenic food environment, and those with genetic vulnerability will have great difficulty self-regulating against what is a very powerful drive. So that's a long-winded answer, Sandra, for it's actually a very difficult thing to do. The modern answer will be, well, we have 3 pillars of treatment. Behavioral therapy works on the frontal cortex. CBT is an example of behavioral therapy, and we went through an example today. Countering internalized weight bias is an example of behavioral therapy. Introducing someone to the concept of wanting and understanding that cravings and wanting are something they're subject to. These are components of behavioral therapy. But the bottom parts of our brain, specifically what's called the homeostatic system and the reward system, we can't get to. But fortunately, it's 2022, and that's actually, because you hear about these other 2 pillars, medication and surgery. That's actually where medication and surgery act. Not in the frontal cortex, not in the decision-making part of our brain. They decrease the craving. So the long-winded answer is, if someone is having great difficulty despite having established and clarified values and meaning and willingness to work hard and they are still struggling, well then, there are other elements of treatment that do specifically reduce the wanting and the cravings, and therefore now they can step into these moments and say, you know what, no thank you, I'm good, I don't need that, that's not aligned with my values, because we've managed the singular central symptom of the risk of obesity, which is wanting or cravings. And so imagine our difficulty. We can't even really explain to patients what we're treating them for, and they don't really, it's hard to explain, and they don't really, and so anyway, I'm not complaining. Being an obesity physician is the single most rewarding field of medicine currently. If anyone wants to challenge me on that, they can. You can. Yeah? Yeah. Oh, a question. Sure, Peter. Yeah.
So thank you, David. That was a great presentation, and I agree that you make complex things really accessible and very important. This is kind of like a meta question around values, and how do we take this values clarification to policymakers and the companies that market such foods? Because at the end of the day, we as a society have created a society that is paid to stay still. Like, right? Till about 100 years ago, we were paid to move, right? Now we get paid to sit still, and we get shackled by and constrained by our Zoom and our meetings and sitting still. And that's society. That's a societal value that is driving. High-dense caloric foods are a societal value. So here we've got one side saying, you know, we want to have healthy people and we want to do this. But on the other hand, the values are pushing the other things. So there's a values conflict going on which the people who bear the brunt of it is all of us.
So where do we start might be the question. I think the best way to answer your question is, what could we do? What could Obesity Matters do? What could we put our heads together and make it an outcome and a take-home message, and it's something we're actually going to do and talk about from this meeting? Arya Sharma always said, you need like an action, right? You can't just end a talk without telling people, okay, you got to do this now, right? There has to be an outcome. So thank you for asking the question. So you mentioned changes in advertising. You can't advertise cigarettes to children? You can't do that? When I drive from up north in Ontario down to Toronto, one of the ideas that comes into my kid's head is they want a Happy Meal because it comes with a toy. That's 2022. So where could we start? Could there come a time where hyperpalatable foods, ultra-processed foods, are not or no longer associated with advertising that blatantly targets children? Is that a place to start? Can we say that children are neurologically and biologically vulnerable, not only because of their age and a lack of a frontal cortex, but some are genetically vulnerable to obesity? So we've got this target group that is vulnerable, and so we can say, let's not allow advertising that is clearly targeted to them as relates to hyperpalatable, ultra-processed foods.
this is just a real sticking point for me, like the food inequity. You can buy garbage that you should not feed to a rat at a cheaper rate than lettuce. And that really is bothersome. But my second question, my observation was this, but my question was, so you've talked a lot about the behavioral piece, the CBT, but you started off by saying how there's the set point and you metabolically then start resisting.
Yeah.
Can you, again, because you can clearly explain the whole metabolic response in about 3 minutes, could you talk about that? Because that's not necessarily attached to cravings.
There's 3 active theories about how the brain defends against fat loss. What we do know is the brain defends against fat loss. If our ancestors lost weight, it was not to look good for a wedding or because of bathing suit season, right? It was because the food supply was interrupted or illness. And so we have a system to defend against fat loss, really so that we are fueled well so we can pass on our genes. That's actually the current understanding. So yes, we have a sense that whatever the highest weight someone gets to, and Sean, you know this isn't clear. We've talked about maybe scarring in the hypothalamus, not necessarily clear how this happens, but the brain will bookmark. I always feel like the bearer of bad news, right? We'll bookmark the highest weight we get to, and then the further you move down from that weight, the stronger 2 things happen. There's only 2 ways the brain will defend against fat loss. It'll defend by the primary mechanism is increasing appetite. The very thing we just talked about that we face, that is the primary central symptom of struggling with weight, gets stronger. That's not fair. Excellent for 20,000 years ago. Perfect, actually, or 40 or 80. And then also our metabolic rate will slow down, which is a secondary effect. The appetite effect is much stronger. And so do we have a way to defend against this? Classically, we could say we cannot change the set point or settling point. But now, in theory, at least qualitatively, the second and third levels of treatment do that. So we see if someone is on a very effective anti-obesity medication, we see them having a dampened defense against weight loss. So they're able to go further and find a lower weight where they're not subject. Think of the whole appetite curve just shifting down. So they'll still lose weight and it'll slow and it'll stop somewhere, but it'll stop much lower than otherwise. And when they're at that lower spot, they'll have more defense against the brain's effect of trying to get them back up. So surgery does the same. So gastric bypass surgery, we see the neurological. Some people think that gastric bypass surgery is mechanical or physical. It's neurobiological. The changes that happen from gastric bypass surgery change the level of cravings. Put someone in a MRI and show them pictures of food after surgery, their brain is going to respond completely differently and less aggressively to food pictures than pre-surgery. So we see the changes again. Obesity is a brain-centered condition. This is where all the genes act. And so yes, it's a great question, but it's also fun to say we don't exactly know how that happens. A guy, if you want to read about maybe the best thinker in this area right now is John Speakman. He works in China, and he puts out papers every 6 months or so. John Speakman is a great researcher and writes well about this concept, and also points out that we don't really know the answer. Was it self-sabotage, or was it biology? Was it actually the normal response to weight loss that will happen in your brain that counters weight loss with increased appetite? 'Cause that's an important distinction, because if it's self-sabotage, that means it's your fault. It's right. Is that part of that automatic storm of thoughts that come in a moment of seeing the scale go up or having an off-track day? Are we back to the resilient subject? See how that kind of sneaks in? That's really cool. And I would invite you to consider that, no, the weight loss was yours, but the weight regain is biology. That's the system. That's how it works. And to answer your question of can we, aside from surgery or medication, I kind of want to double down on effective anti-obesity medications, because maybe not everyone knows this, but we are in a particularly very exciting time with the onset of safe and effective medications that will do exactly really what you're asking for, which is to dampen the brain's response to try to get me back up, freeing me to think less about food and be less hyper-responsive to cues and to have lower cravings. And if this is a chronic disease and if medications are safe and effective for long-term use, then we might very well be in the direction, thankfully, in 2022, finally, where we actually can support. Now, not everyone is interested in medication, and I get that. I get that. And so behavioral therapy is certainly an evidence-based method. We just went through behavioral therapy. I already invited you to think that you don't self-sabotage yourself and it's biology that's causing weight gain. So there's lots to work on in the behavioral field. But medication is, if people don't know that, medication is currently, as a clinician who's worked for almost 19 years in this field with only behavioral tools, to have effective and safe medication for patients, it's a very positive experience for the absolute great majority of them. And so, and it's only becoming medication is only becoming more effective. We're kind of in a stage, and this might sound foreign to you, but we've been at this stage with anti-obesity medications for the last 15 years, and right now it's just like going like this. It's just going up in safety and effectiveness.
So your speech today was wonderful, and I feel like I'm the poster child. When you talk about obesity, I'm the poster child. I'm not alone. I've had conversations with lots of friends and people I've connected with. I'm a nurse, so I've worked in primary care, and I've seen people have the struggle, so I was able to attend a lot of sessions and information sessions about this sort of stuff. And then even myself, I decided to take a program. I've been involved, you name it, Weight Watchers, TOPS, keto, non-keto, Dr. Atkins back in the day, you name it, I've done it. And I've had a lot of really compassionate people in my life, like compassionate providers like yourself who have, sympathized, understood. It's been my story. Everything you've said has been my story. Yet here I am, still trying to find the answer. So here I come in here and I'm like, yes, acceptance is the answer. This is what I'm trying to promote now, because I'm like, clearly I can't do it because I don't have enough values, motivation, all of these things just makes complete sense to me, right? Just making this up as I go. So I'm like, here I am, what do I do? What does someone do in my position? You want to get healthier. And so my doctor recently prescribed me Jardiance, which is on your list. Jardiance and Saxenda are like these two, and Ozempic is another one that's up there as well. I know, I've done my research. A lot of people out there in this industry just want to make money from it because it is a cash grab for a lot of people. So where do you get good information? Where are you getting all this stuff? So Jardiance has been sitting on my nightstand for 2 months now, and I'm reluctant to try it. And I said to my doctor, what's it going to do for me? He goes, it'll help you with the cravings, he said. I said, well, how much can I expect to lose? He goes, well, you can lose 10 to 15 pounds without even trying. I'm like, wow, significant. Thanks for the help. That means nothing to me, right? I'm not looking for the right answer. I'm not looking for anyone to give me the solution. But there are other big problems. This is all, we're all here for the same reason. And you can stop the advertising and you can promote all these things. And where do we start? Let's get it started. But I see it every day. I see it in my relationships. I see it in my friendships. I know what I go through. So if I feel like I've been there, done that, what's different today?
So if I hear your question correctly, and thank you very much for sharing, you have lived the experience of struggling with your weight, I'm assuming lifelong.
Lifelong.
You also mentioned that you've tried, you name it. I've tried TOPS, I've tried Weight Watchers, I've tried keto, I've tried paleo and schmaleo and all of them.
Yep.
I've even gone to my doctor and asked them, what can I do? I'm wondering if you would consider the following. All of the things that you have mentioned, and this is, I take blame for this. The medical community should take blame for this. All the things that you've mentioned that you have tried to manage your real chronic and complex medical condition, none of those are actually treatment for what you're struggling with. Sean Wharton is here. Sean Wharton is the chair of the Canadian Clinical Practice Guidelines. We wrote chapters on all of these things to point out, actually, if you follow 100 people for 6 months or a year, it actually doesn't work. You'll hear stories of that one person who did great, but we can't rest on anecdotal information. We have to act as responsible healthcare practitioners and bridge the gap between effective obesity treatment and people deserving of effective obesity treatment. Jardiance is actually not an anti-obesity medication. I'm actually not really sure. I mean, I understand maybe why in a very roundabout way your doctor might have prescribed that medication, but I think it exemplifies what is our bad, the medical community, is that we have not been there. I call it the grand apology. Here is this real medical condition, a discriminated people, but yet we actually are at a stage right now where we can't take it anymore, because the difficulty is not that individuals are struggling alone, it's that individuals are struggling alone while actual effective treatment exists. And there's just this gap between these individuals who are struggling and effective treatment. And how are we going to, and Obesity Matters steps in and says, well, we're going to be one of the voices that helps bridge that gap. We're going to help communicate the principle that obesity is a real disease, it's not someone's fault, and treatment exists. I understand the acceptance model, and the acceptance model, if carrying extra weight didn't possibly affect negative health, and if no treatment existed for those living with obesity, I would agree that acceptance might be all that we have left, and it would be a key in destigmatizing and countering bias and helping someone live a life that is fulfilled, knowing that they've done what they can and they're doing the best they can with the cards they've been dealt, and to accept that. I agree 100%. But if carrying extra weight creates poor quality of health or poor quality of life and treatment exists, I don't want the inertia of acceptance to be where people land necessarily. I want them to at least consider that effective treatment exists. And so it's an interesting, is it possible that all the things that you've done, none of those are effective treatment? It's very natural that you would struggle. 2022 is a different year. We really are moving forward in a very fast pace. And behavioral treatments will be available to more and more people, and more effective and safe medications will be available to more people. And what you describe, hopefully, my wish, becomes something of the past, where someone is trying on their own to manage a chronic disease. We don't tell people with depression to cheer up. We don't tell people with asthma to breathe deeper and cough less. And yet, people living with obesity are being told to just eat less and move more, or cut out carbs, or go to the gym, or do intermittent fasting. So what's really fascinating is when people receive authentic and ethical and effective treatment, I see this every day, I see 16 patients a day. And I say this all the time. I'm like, oh, so now you're receiving effective treatment. Doesn't this tell us that all along you had the motivation, you had the focus, you had the self-regulation skills, you had the key values, you had all of these things, but for the very strong symptom that was driving great difficulty. Even as you lost weight, it got stronger, the symptom and the drive to get. So if that gets dampened, doesn't this mean you always had all these skills?
I, like many other people, have also been struggling with weight my entire life. I'm finally at a place where I feel like I'm dealing with it well. And I think one of the words you said, especially to her question just now, is alone. And I know as a child especially, the amount of negative comments that I would get, or what was worse, the encouragement I would get from people that I love, but because it's about weight, I was so scared to accept it. Or I would be very combative against anyone that said anything that was even remotely related to weight, that I was never willing to acknowledge that they were saying something out of love to help me, and rather just protect myself. And so I think from my experience, and I think the reason I'm on a really good path today is because I finally figured out how to accept that support from the people in my network and the people that I love and care about me. So how can we try and create better language around that as we are in 2022. Everyone is accepted today, or should be. Mm-hmm. What efforts can we start making in that direction as well?
If the question is what can we change so that an individual will be able to feel comfort in getting support from those around them, I think we circle back to where we started our clinical practice guidelines. We start by communicating that struggling with weight is a real condition and not someone's fault and something for which treatment exists. I'm actually curious, you still have the microphone in your hand. What does that message sound like? Does that sound like intellectually you get it, but emotionally it's a little hard to wrap your head around the idea that, well, right, that it's not my fault and that this is a genetically conferred, brain-centered, environmentally influenced, progressive condition that you've likely never received comprehensive treatment for? What does that messaging feel like? Is it?
I think my immediate response to that is I think every obese person's background and history is so different, the trigger words are so different, the reasons are so different, that my answer is going to be far different to anyone else, or will likely be different to most other people. And for me to hear something like that today, and where I am, I get it. But me as a 10-year-old girl that was, a lot larger, wouldn't help me. Or I don't think I would have been in the mental state or the mental capacity to understand or accept what was being said. And I think that was the hardest thing for me to overcome. And I think it was like earlier this year. That's when I had that moment of enlightenment of like, oh, I want to have the value-based life. I actually laughed at your first example on scuba diving because that is my big motivation right now. I love scuba diving and I want to keep doing it with kids in like 20, 30 years. But where I was going and the direction I was heading in, it wasn't going to happen. And seeing the people in my life, like my family, were supporting me, and I was like, you know what? My mom has constantly been saying, why don't you consider doing this, or this other diet, or exercise more. There was a day she finally said the right thing to me, and I was like, okay, I think I'm ready to start approaching this. And I did. And it was that really got me onto a path that 6-7 months later I'm the smallest I've been in a very, very long time, and I think I'm on a path where this is continuing. Hopefully keeps going down, but I know it's a roller coaster.
Thank you very much for sharing. That's and if I could at all kind of normalize your experience, quick psychology. So I'm a GP psychotherapist. I'm going to switch into my GP psychotherapist for a moment. 10-year-olds and 11-year-olds and 8-year-olds and 9-year-olds have an intrinsic self-critic. And ultimately, if we're told at 8 or 9 or 10 or 11 that there's actually something wrong with us, it, by definition, cannot be taken constructively. What it means is, at its worst case, is if I don't change this, I actually risk the bond that I have with this person who's telling me that I really should lose. And now that I've not succeeded, I'm really actually driving a wedge between me and this person, and I'm even maybe in fear of abandonment because they really want me to and I can't. Clearly there's something wrong with me. Clearly I'm different. And that's the source of intrinsic weight bias. And that's why we start the guidelines there. That's how it goes back like a thread to 8 and 9 years old and 10 years old when the coach told me this or my parent told me this. And yes, it was loving, but in theory, there is an art to supporting someone who is at risk of struggling with obesity as a parent that is not necessarily intuitive. Telling someone they should do this and they should do that, or they should try this diet or they should try that diet, is in theory, it comes from a great place, but it doesn't work.
So, hi everybody, my name is Meena. I'm a pharmacist working at LMC in Brampton. I work closely with Dr. Bajaj. And we do some work with obesity, but we do a lot with diabetes. So my question is about diabetes and obesity. So oftentimes, my colleague and I, Kieran, we are training people on how to start insulin. And we know that this is going to lead them to the path of weight gain eventually. And that some of these patients are resistant to starting for that very reason. And they're like, I don't want to gain weight. I know people that have started insulin and they're now taking different types of insulin and they're gaining weight really quickly. We can't deny that to the patients, but eventually we even see them being put on semaglutide or Ozempic in addition to insulin. My first question is, how can we help these patients to not gain so much weight along the way, which is kind of, obesity to me is also hormonal, not just mental, it's both. And I think because we're using a growth hormone in patients that need it, how do we kind of limit the weight gain or help them to manage their behaviors as they start insulin? Second question I have is, because we're using Ozempic, I see a lot of people on Ozempic now at 1 milligram, now at 2 milligrams, and soon to be higher doses when it's approved or when it's marketed. When in your experiences, is there any way to get these people off Ozempic in the future? And I hear the answer to the question already, because it's a chronic disease, so you may not be able to get these people off, and because if you do, because of our set point, they're just going to go back up. So my question is this a lifelong therapy for people to expect?
So let me work backwards. In theory, both excellent questions. In theory, anti-obesity medications are meant for chronic use. Obesity is a chronic disease, not the least of which because as you lose weight, the brain defends against fat loss. And so if someone loses 20% of their body weight, I actually explain to patients that it's a very easy medication to come off of. And I invite patients to consider that yes, this is a chronic condition, and yes, the logic of anti-obesity medication, like any other chronic disease, is meant for chronic use. Remember, the conversation that never happens in a family doctor's office is the following. Doctor, good to see you. Yes, patient, what brings you in? Well, the weirdest thing happened. Oh, what happened? Well, remember that blood pressure medication you put me on? Yes, the one that brought your blood pressure normal. Yes, and reduced my risk of stroke and heart disease, you told me. Yes, that one. So what's the weird thing that happened? Well, the weirdest thing happened. I stopped taking the medication and my blood pressure went back up. So that's a conversation that never happens in a family doctor's office. Why? Because everyone understands that that's a chronic disease. And if lifestyle efforts were not successful in bringing down the risk factor and they were still living with the risk of heart disease and stroke, that this medication is going to support them. But of course, if they come off the medication, the condition will come back. So that's the logic. Though I invite patients, I say, listen, you can come off this medication at any time. In fact, I'd be very happy to support you, because it's a really interesting experience for someone to say at a lower weight, here's my life with, here's my life without, let me decide. Right? Autonomy is so important in a patient's path. Do you know that as a clinician, at least I think for the last 15 years, I've never told a patient once what to do? I'm an entirely non-prescriptive clinical practice. I'll invite patients to consider this might be helpful. If that's something you're interested, it could be a very reasonable experience for you to discontinue the medication, stay close. And it's a great question. Here's my life with, here's my life without. Is that something you'd be interested in finding the answer to? Because now you're down by 20 or 22 or 24% of your body weight. If that's an interesting question to you, very happy to support you and help you answer that question. And whether without the medication you decide to stay off the medication and go back on it, I would invite you to consider that that's, of course, your decision. And I'll support you in either of those decisions. It's patient autonomy is key. And then to answer the first question, actually remind me the key points of your first question.
Insulin starts.
Right. So. Yeah. We are in a fascinating, so there was a new clinical practice guidelines released, I think maybe 2 weeks ago, at a European diabetes conference, which now, big scratch your head moment, now suggests that first-line therapy for type 2 diabetes should include obesity management, because 95% of those who struggle with type 2 diabetes live also with obesity or overweight. And actually, we have really interesting evidence that even just excess adiposity in the center, even in someone who's not classically considered obese, but is living with diabetes, that also for them reducing intrinsic adiposity actually supports either a regression or even a remission of their diabetes. So can you believe, first off, that it's 2022, and there's a medical condition called diabetes, primarily driven by excess adiposity. And if you go to one of the 100 diabetes treatment centers in Canada, and if you ask the nurses and the dietitians and the physicians who work in these, what is their approach to treating obesity, which we now understand to be the primary driver of those who are living with type 2 diabetes, there are no obesity treatment principles included in this nationwide network of government-paid healthcare practitioners who are treating diabetes. That is going to change. It's going to change quickly. Medications like semaglutide are bridging that gap. I'm involved in a process between Diabetes Canada and Obesity Canada to create educational material to exactly answer that question. How can we be treating diabetes and not treating obesity at the same time, especially since effective treatment now exists.
I have a saying in my practice that acceptance is a starting point, not necessarily an end point to something. So we can accept that there's a set point. We can accept our obesogenic environment. And the question then becomes perhaps, what are your values in light of that acceptance? What is the meaning that you can ascribe to yourself and your behavior given that acceptance? So for example, our body may defend in terms of increased appetite to our set point. Says nothing about what we can do in terms of exercise, and not necessarily to lose weight, but exercise for overall improved cardiac health, joint health, better movement, et cetera, et cetera. So the value gets, our values can still have a lot of priority, even if there is a set point there as well.
So just to quote Michael Vallis, proper and appropriate psychological tools can be used to support, but also can be used as a weapon. Why I bring that up, and I love the idea of clarifying and reflecting on values, but we heard Sandra earlier say, my doctor leaned into me and said, isn't this important enough to you? Isn't this really important to you? Don't you value being healthy? That's not a treatment. So, right, when I represent values, I mention that as an intrinsic motivation to treatment. Again, we wrote guidelines. The guidelines are there's a behavioral therapy, there's a medical therapy, there's a surgical therapy. Why do we only describe 3 pillars? Because there aren't any other ones. I'd love to say there's 4 and 5 and 6 pillars, but there's only 3 things that actually work if you take 100 or 1,000 people and you follow them for 2 years, right? So we're not at a mystery point as to how to support individuals struggling with obesity. We're beyond that point. There's no question now. We don't have to ask, how are we going to figure out how can we effectively support patients living with obesity? Boy, I wish we had treatment available to us. We're fortunately not at that stage anymore. Now it's about closing the gap between those who are living with the disease and effective treatment which exists. That's really I think the kind of, it's actually in their vision statement. It's actually in the Obesity Matters vision statement. It's about closing that gap and allowing people access to support for their real medical condition. So excellent, and thank you for the question.
Well, I just want to thank all of you for coming out tonight. It means a lot to me personally, and it means a lot that I have supporters like Dr. David Macklin and Dr. Sean Wharton and Dr. Sandy Van and all of you who are here today. It gives me goosebumps, it gets me emotional, just because I know you guys believe in me. I know you believe in the cause that we are doing, and it just means a lot for your support. We launched Obesity Matters 18 months ago, and we've gained a lot of traction and visibility in these 18 months online. Thanks for partners like Healthing, because you've really taken us up there with with all your profiling on us. But now, today, it's all about building communities. And I'm so grateful that you've all come here to be with us. We formed this little local community, and this is how we're going to start. This is the start of getting volunteers involved. If any of you want to be involved, just let us know. You all have my email, reach out to me. We want to start now growing more communities with the GTA, with Toronto, and then in other communities across Canada. And we need your support. So once again, thank you so much for coming and supporting Obesity Matters.